Okay, here we go. I place my secondary incision about 2 clock hours from my primary incision. Jo places his secondary incision about 4 clock hours from his primary incision. We both put in lidocaine into the eye. I coat the cornea with OcuCoat. He fills the eye with Amvisc or Amvisc Plus. My primary incision is just a straight planar incision parallel to the iris. Jo's primary incision is a shelved incision. I make a flap using the cystotome, and because my cystotome is attached to the OcuCoat, I just keep the anterior chamber filled, and I make a 5mm round Capsulorhexis using the cystotome. Jo uses the cystotome to create the flap. I usually go clockwise. He usually goes counterclockwise in movement of the flap in the anterior capsule to create his Capsulorhexis. I hydrodissect using a chain cannula. My microscope light illumination is brighter. I have the room lights on. You can see the room light reflection in the cornea. Jo uses a chain cannula. He uses lower illumination. The room lights are off. You cannot see the room light reflection on his cornea. It appears on these two cases our microscope illumination settings are somewhat similar in terms of we have all three microscope lights reflecting off the cornea. I use a chopping technique where I create a central groove, and then I generally place my secondary instrument and do a kind of chopping technique. Jo creates kind of a traditional divide and conquer technique where he creates a cruciate groove and then uses the Olson chopper made by Epsilon to split the nucleus into quadrants. So right now we're both removing the nucleus. These are similar types of cataracts. We're both sitting temporally. And at 3:29, John is done with phacoemulsification of the nucleus. And I'm a little bit behind him. John is now introducing the irrigation and aspiration instrument. I'm still removing the nucleus. We always want to we always want to emulsify centrally, so I tend to bring everything toward the middle of the eye before I emulsify it. Now I'm done removing the nucleus. I apply a little bit more lidocaine. John is well into his aspiration of the cortical remnants. Now I'm introducing the irrigation and aspiration device. Our plan is to insert a Panoptix lens into both these patients' eyes. Again, the room light is off for Dr. Odette. The room light is on for me. Dr. Odette uses a lower microscope illumination. I use a higher microscope illumination. He has now removed the cortex and is refilling the eye with probably Amvisc Plus. Now I've removed the majority of the cortex. John is polishing the posterior surface of the anterior capsule. I am aspirating the posterior capsule using the single-use capsule guard made by Bausch & Lomb. I'm removing cells from the posterior surface of the anterior capsule. John is polishing those same cells with the sweeping device that polishes the posterior surface of the anterior capsule. I'm getting subincisional cortical remnants out of the eye. I think John has now asked for the room lights to be turned on because you can now see the reflection of the room lights on the cornea. I think he does that to load his lens. And now he's inserting the Panoptix. And now he's just rotating the lens into the proper position, allowing the haptics to expand and for the lens to unfold. I've now filled the eye with OcuCoat. And then I polish the posterior surface of the anterior capsule that's closer to the primary incision. John is now removing the viscoelastic from in front of and behind the IOL. He has a Panoptix lens well positioned inside the capsular bag. I'm now inserting the Panoptix lens into the capsular bag. We're both operating on the left eye and sitting temporally. So we've tried to do as close to an apples to apples comparison. I have a little snafu with the capsule guard, so I adjust it before I place it into the eye. It looks like at this point John has removed the viscoelastic from the eye. I am still removing viscoelastic from the eye. His lens implant appears well centered, and he is done at 8 minutes and 6 seconds. And I am continuing on, removing viscoelastic now from behind the implant. And in general, the consensus is that Dr. Odette is a faster surgeon than I am. And probably he finishes surgery about a minute to a minute and a half before I do on most cases. So here we are now. We've removed the viscoelastic. The lens implant is well centered. We hydrate our incisions. Make sure the lens implant is well centered. In both of these patients, the rhexis is in the 5 millimeter range, well centered. The lens is well centered, and now we're done.